Hello everyone, my name is Heder de Vries. I'm a physician and researcher from Amsterdam, and in this educational video session we will be covering how you can start using esophageal and transpulmonary pressure measurement in your clinic, demonstrating it with the Getinge Servo-u ventilator. What we will be covering is the contents of the esophageal balloon catheter package, how you connect it to your patients, how you connect it to the ventilator, how you validate the positioning and filling of the balloon, and how you can start conducting the first measurements in your own patients. There are multiple options of packages to use when you want to start doing esophageal and transpulmonary pressure measurements. There's catheters that are just one singular esophageal balloon, but there's also more advanced catheters that combine a nasogastric feeding tube with an esophageal balloon. And the one I will be discussing in this video is the combined nasogastric catheter with an esophageal balloon made by NutriVent, which is distributed by Getinge to be compatible completely with the Servo-u ventilator. But there are other options, and I would suggest that you always read the instructions of the manufacturer of the catheter that you decide to use. Let's open the package and see what's inside. The package is very easy to open, and it contains a few different things that we will need when doing the insertion. The catheter itself is a 14 French nasogastric feeding tube. What we've shown here on the table is the contents of the package of the NutriVent single esophageal balloon nasogastric catheter. The most important piece that's in the package is, of course, the nasogastric feeding catheter. As you can see, it has a standard connection piece for nutritional systems. It has this green wire coming out that's connected to the esophageal balloon. It has its own lumen, and over here we can see the esophageal balloon. It's about 10 centimeters long, and right here in the middle you can see a radiological marker, and that marker can help you in placing the catheter and confirming its position, because it will show up very clearly when you take a chest X-ray. What's also in the package is this connection piece. It comes with stiff tubing. It has a three-way valve with luer locks that you will connect here to your esophageal balloon, and this piece over here will connect to the module, the esophageal and transpulmonary pressure module made by Getinge, which will be inserted into your mechanical ventilator. Moreover, there's a 10 milliliter syringe with a luer lock that you can use to fill the balloon after connecting it through the three-way valve over here. And lastly, there is a guide wire included in the package that you can use to place in the nasogastric feeding catheter before you insert it in your patient, to help in making the insertion go as smoothly as possible. So now we have inserted the nasogastric catheter like we would any nasogastric feeding catheter. We've used lubricant gel, we've positioned it as we would do according to your standard local guidelines for nasogastric feeding tubes. And most guidelines will include taking an X-ray to ensure correct positioning. And the good thing about this specific catheter is that there is a radiological marker at the balloon. So if you take an X-ray to confirm adequate positioning, you can also see that the radiological marker should be in the lower 1/3 of your patient's esophagus, which can help you with finding the correct positioning. After we've placed the catheter, we have to connect the connection pieces to connect the esophageal balloon to the Getinge Servo-u monitor. We do that with a usual luer lock connection. You connect the three-way valve to the catheter on one end. Make sure the connections are quite tight, because you do not want air leaking out of the balloon over time, as then you would have to do more air filling and positioning maneuvers. And when you've made the luer lock connection, you take the other piece that's provided and you insert it in the Servo-u module that is required for the esophageal and transpulmonary pressure monitoring. After you have placed the nasogastric catheter and connected it to the ventilator, the step is to fill the esophageal balloon. You take the 10 milliliter syringe that's provided, suck in 4 milliliters of air, you connect it to the three-way valve. Then I turn the three-way valve to make sure the air enters the esophageal balloon. I put in 4 millimeters once, and this will expand the balloon. And then I take out 1.5 milliliters. So currently there is 2.5 milliliters in our balloon, which is our starting point. And from there on, we will titrate more exactly. And importantly, at this point, you have to close the three-way valve to make sure air is not leaking out into the environment. So now we have placed our catheter, confirmed positioning with an X-ray, and we filled the balloon. It's time to check whether the positioning and the filling is good enough for us to do reliable clinical measurements. First, what we have to do is we have to go to the screen in the ventilator that shows us the esophageal pressure. For this, you press on Fuse, and then at the bottom there's a special view called Pes and PL monitoring. We click on this, and what the ventilator will show us now on the top screen is again the airway pressure as you're used to seeing. Below that we see the esophageal pressure, and the ventilator will calculate for you on its own the transpulmonary pressure continuously, so there's no effort for you in this. And what we can observe very clearly is that esophageal pressure is going up during every inspiration, becoming more positive, and this means that this patient has no spontaneous breathing effort at all, and all the work of breathing is done by the ventilator. We will now confirm adequate filling and positioning of the catheter, and one of the hints that you can use is whether you can clearly see cardiac oscillations. If the esophageal balloon is correctly positioned in the lower part of the esophagus, you can actually see the activity of the heart because it's very close to the esophagus, and the esophagus has a flaccid transmural pressure, so the cardiac oscillations can be very clear. We can see them over here. Very regularly, at 100 beats per minute more or less, we see these small oscillations in the esophageal pressure tracing, and this is a first hint that the catheter is positioned correctly. But we will need to use a hold maneuver to confirm the position. So now we have placed our catheter, confirmed positioning with an X-ray, and we filled the balloon. It's time to check whether the positioning and the filling is good enough for us to do reliable clinical measurements. To help you with this, the ventilator contains a tool. You press on maneuvers, and then at the bottom you see the Pes catheter positioning tool. You press this, and then when you press start, the ventilator will start an expiratory occlusion for 10 seconds. And in these 10 seconds, you have to do your thoracic compression. I press start, I walk over to my patient, place both hands on both sides of the thorax, press down on the thorax once, release, twice, release. The tool has calculated the ratio for us, and it shows that the ratio between the rise in esophageal pressure and airway pressure is 1.09. We want this ratio to be between 0.8 and 1.2, and as close to 1 as possible. So 1.09 is very acceptable. And what that ratio means is that now we know the balloon is at the adequate position and filling, and we can use the esophageal pressure readings to conduct reliable measurements in our patient now. I will now show you how you can confirm adequate positioning of the esophageal balloon and adequate filling in a patient that is breathing spontaneously. As you can see, this is a patient ventilated in a pressure support mode. And we can see that he is triggering every breath by the ventilator because the ventilator colors the flow tracing white, meaning it's detecting inspiratory flow and providing pressure support. And now we no longer need to compress down on the thorax to confirm positioning. We can go straight to the positioning tool. So once again, you click on maneuvers, you click on the bottom button, which is the Pes catheter positioning tool. And we press on start, which will administer the expiratory hold. And now when our patient is trying to inspire, you can see that airway pressure is going down and esophageal pressure is going down as well because the patient is trying to inspire against a closed airway. And once again, the tool will automatically give us the ratio between the drop in esophageal pressure and the drop in airway pressure. And we want the same ratios here, so between 0.8 and 1.2. And as we can see here, the ratio in this specific patient is 0.95, which is very good and means we can trust these measurements to make our assessments of the patient. One thing that you might run into when you start doing this in your patients is that the positioning ratio is not between 0.8 and 1.2. And when this happens, you might have to check several problems. First, I'll demonstrate how this might look like. So once again, we're going to maneuvers, Pes catheter positioning, we press start, and we have someone compress the thorax of our patient. And what we can see now clearly is that airway pressure is rising, but esophageal pressure is rising to a much lesser extent. And as you can see, the ventilator now tells us that it's unable to confirm the positioning because esophageal pressure barely changed. When this happens, there's a few problems you need to consider. First of all, the catheter could be placed inside the trachea. This is very rare if you took an X-ray to confirm positioning, but it is something you should consider. Second, make sure that the catheter is still positioned at the same depth as the moment you took the X-ray. It could have moved up. It might even be inside the patient's mouth if they're coughing. So make sure the positioning of the catheter looks good on the outside. Last, the most common cause of this problem is that there's a leak somewhere in the system. And usually it's at the luer lock connections or sometimes at the connection with the ventilator. So check all the connections, make sure everything's very tight, and then go through the steps again of filling the balloon with the volume that is recommended by the manufacturer. For this balloon, I would once again put in 4 mL, take out 1.5, and then see once again whether esophageal pressure is showing any movements during inspiration. What I'll discuss right now is how to manage the esophageal balloon over time in your clinical patient. First thing to know that's very important is that you have to confirm the positioning of the balloon every time you want to do new measurements. So if I were to leave the patient and come back 2 hours later to do new measurements, I would do these steps that I've shown you before to confirm adequate positioning and filling again, to make sure that the data that I'm getting from the ventilator is reliable and can be used to make clinical decisions. So that's a first important step to know. Secondly, I tend to go back to the advanced monitoring screen that doesn't show esophageal pressure when I leave the patient, because I found that if people see the screen and they don't recognize it, it can lead to confusion. So I make sure that the screen is always at the screen that is most comfortable to the nurses attending the patient. So I would go back to views and put it on advanced whenever I leave the patient. And when I would come back, I would go to the advanced screen again, showing the Pes monitoring, and do an occlusion again. For this specific nasogastric catheter, I tend to keep the volume in the balloon for prolonged periods of time, but always check the manufacturer's manual for the catheter that you're using to see whether they recommend emptying the balloon when you leave or keeping it filled. I found that this balloon can remain filled for hours on end and still be reliable, but I do check it every time. We are now at the esophageal and transpulmonary pressure monitoring screen, and what I want to show you is how this screen is set up. At the top, we see the same tracing we're used to, the airway pressure, and below that there is esophageal pressure. Below that, in orange, is the transpulmonary pressure, which is calculated by subtracting esophageal pressure from airway pressure, and the ventilator does this for you continuously. So there's no extra effort for you there. Below is flow, and below that is volume. Now what you can do is you can tap the screen and hold on any of these tracings, and you get this screen, the layout screen, that you can modify to your requirements. What I like to do is to take out volume, because it means the other traces will be slightly bigger and easier to see. And an extra option that you can do is to overlay Pes esophageal pressure over the airway pressure tracing, which I will show right now. And if you accept this, you can now see we have esophageal pressure overlaid over airway pressure, and we have esophageal pressure and transpulmonary pressure. I usually set up the screen like this, but know that you can modify it to your own requirements if needed. What I will explain you right now is which parameters this specialized esophageal and transpulmonary pressure screen provides to you and how I would use those in clinical practice. So from top to bottom, this screen tells me PLEY, which means the end inspiratory transpulmonary pressure. Currently it's 12 centimeters of water, and this parameter reflects the stretch posed on the lung tissue at the end of an inspiration. It's important to know that these are dynamic measurements, and for them to be even more reliable, it's better to measure them in static conditions. But because currently we are ventilating this subject in volume control and there's a clear plateau pressure, they are likely very close to the values I would obtain with hold maneuvers. Below that is the delta Pes, which is the change in esophageal pressure during every breath, and this parameter is very relevant when your patient is breathing spontaneously. It's not something I look at often in patients on a controlled mode of ventilation that are not actively breathing. Below this is the transpulmonary driving pressure, PL drive. Again, this is a dynamic measurement. For it to be completely reliable, I would need to do hold maneuvers, but this parameter tells you something about the energy transmitted to the lung during every breath. And below that is the PLEE, which is the end expiratory transpulmonary pressure, which is something that I use to set PEEP, especially in obese patients, and we'll cover that very shortly. What I'll show you right now is how you can obtain those static measurements. What I'd like to do is go to Maneuvers, Static Measurements, press the recording button at the top right corner of the screen, and start with an inspiratory hold. And I'll hold this for about 3 to 4 seconds. This is usually enough to get a reliable plateau, release it, and then in the next breath I'll give an end expiratory occlusions for 3 to 5 seconds. Now the ventilator will already tell me some of these static measurements that I just conducted, and I find that these are usually reliable, but I do like to check them myself in the recording that I just made. So we close this screen. We go to the top right button on the ventilator showing a stack of papers, which is the stored recordings. We go to recordings and it will automatically open the last recording we made. And now we have to look for the occlusion maneuver. And over here you can see a prolonged inspiratory plateau. We can put the cursor over here and write down the pressures that we see. So we get the airway pressure, the esophageal pressure, and it will automatically calculate for us the transpulmonary pressure. And as you can see now, it is 12, which it also was during the dynamic conditions, but this is not something you can always trust, so I would always suggest to do these static hold measurements. Same thing is true for the expiratory transpulmonary pressure. Here, during the next breath, I gave a prolonged expiratory occlusion. We can put the cursor over here, do our measurements again, and what we see is that airway pressure is about 6, and esophageal pressure is about 8, meaning that end expiratory transpulmonary pressure is -2. One thing that can be very useful when you have this esophageal balloon in position is you can use it to titrate PEEP. There are many ways to titrate PEEP in your patients, and I find that the specific method where you titrate it to end expiratory transpulmonary pressure is especially useful in patients that might have a very elevated pleural pressure. One example would be obese patients. Because of the large amount of weight pushing down on their abdomen, they tend to have a higher pleural pressure, and this means their lungs are more likely to collapse. And you could set a high PEEP, or you can use the esophageal balloon to titrate it very precisely. And research has suggested that targeting an end expiratory transpulmonary pressure between 1 to 2 centimeters of water is the most beneficial for these patients. As we can see on the screen right now, the end expiratory transpulmonary pressure is -4. This might mean that this patient has an increased chance for collapse of the lung and perhaps even cyclic recruitment. So in this case, I would try to increase PEEP slightly to get this number to be just positive. Because it's at -4, I would personally start with increasing PEEP by 5, making it 1 centimeter higher than what we see here on the screen. So I would go, in this case, from 7 to 12 centimeters of water. And we can see immediately on the next breath whether this is enough. As you can see on the screen, end expiratory transpulmonary pressure is now close to 0. The ventilator also shows us the number 0.1, so it's slightly positive. And I think that for this patient, this would be a very acceptable level of end expiratory pressure. So this is how I would use it for this specific patient.